عارف أحمد تأخر يمكن. عموما يعني thank you very much Mr. Chairman, dear colleagues, for allowing me to speak about our experience in management of cardiovascular therapy in pulmonary embolism Acute University experience. وأنا مش شايف السلايدز عندي هنا. تمام. Because we have international speakers, I want to show you where is Acute. Acute actually is in the middle of Egypt, between Cairo and Aswan, and this is our university hospital. It's a huge campus with 8 specialized hospitals inside Acute University, and we have a 5,000 bed in all our university hospitals. We started as a pulmonary embolism response team initiation group. This is an initiation group in 15th of January 2021, and we are joined in 10 different specialties. The main specialties which compress the per team is the chest department, intensive care units, different intensive care units. We have 25 intensive care units in Acute University Hospital, interventional cardiology team, and cardiac surgery. And this is the active group. So we have an initiation, the head of the departments, then we have a 10 active group joined to make the paired active team, and this is the algorithm we are using. So after we diagnose and risk stratify the acute pulmonary embolism, all the cases jump into one WhatsApp group, and we decide, the pair team decide what to do next, thrombolytic or to do the catheter-directed therapy, and which type of catheter-directed therapy to use in each patient. This is the main problem. The catheter-directed therapy had been upgraded in the last ESC classification 2022 for management of pulmonary embolism from 2B to 2A. So it's a rapidly growing subject. And in Egypt, we have 3 main types of CDT we can work on. And this is our Acute University experience. So we have the standard, the pigtail catheter-directed therapy plus minus thrombolysis. We have the ecosystem with ultrasound-assisted CDT. And we have the penumbra aspiration, so we do thrombectomy without thrombolytic. Our first paper published in the Egyptian Heart Journal in 2021 about the efficacy and safety of hydromechanical defragmentation in intermediate and high-risk pulmonary embolism patients, where 166 patients confirmed pulmonary embolism seen by the pair team, and where 50 of them of high-risk pulmonary embolism were head-to-head managed as thrombolytic against hydromechanical defragmentation. Most of them were contraindication for thrombolysis, and this is the results. We had a higher reduction in respiratory rate 24 hours, 48 hours and 30 days, higher increase in the systolic blood pressure in the blue arm, higher reduction in the pulmonary artery systolic pressure, and increase in the oxygen saturation with a success rate of 80% in the hydromechanical or CDT group. I will present 3 different cases from this group, and nowadays. This first case is a 36-year-old female married with 2 sons. She had a cesarean section from 4 days ago. She presented to the emergency department with a syncope and sudden onset of dyspnea. Vital examination, tachycardic 110, hypotensive, systolic 70, respiratory 35, so tachypneic. ECG showed that sinus tachycardia was right bundle, hypoxic, oxygen saturation 88 on room air, and troponin is positive and creatinine is normal. All these patients has to have an echo and a CT pulmonary angiography if not contraindicated. The echo shows severe tricuspid gauge, elevated pulse, dilated right side, reduced TAPSE, positive 60-60 and McCollin sign, and the CT shows a huge thrombus mainly in the left pulmonary artery, but also in the main. So we have a high-risk pulmonary embolism patient, contraindicated for thrombolytics, as then from 4 days. And the decision was to do at that time 1 year from 2 years now. Hydromechanical defragmentation is a big deal, and if possible, we can use a 1/3 dose of alteplase or actylase intrapulmonary. And this is how we do it. We just put a big tail, and if you can appreciate here, the thrombus is huge. You can see a big thrombus at the site of rotation of the big tail, where we just fragment it to open the way for blood pressure patient shock and contraindicated for thrombolytic. What can we do at the time? So, however, it was successful. After 48 hours, we have a higher blood pressure, 120 over 70, heart rate is 80, and the respiratory reduced to normal. Oxygen saturation on room air is 96%. The invisibly managed mean pulmonary artery pressure is 20, and by echo the pulse reduced to 40. Our protocol is to keep the bacteria for 48 hours and give intrapulmonary heparin as long as the patient is shocked. Once he is hemodynamically stable, we remove the bacteria, give enoxaparin for 7 days, then shift to NOAC after 6 months. And routinely, all patients for follow-up after 1 month, they do a CTPA. We have no pulmonary embolism. Patient is well and fit for 1 year now with no residual pulmonary hypertension. This is my first case. Second patient is a 70-year-old male. This is a 70-year-old male farmer with a history of fractured head of femur 2 weeks ago and underwent surgical fixation and presented with sudden onset of dyspnea and hemoptysis. He's tachycardic, heart rate is 130, shocked, blood pressure is 60, systolic, tachypneic, heart respiratory is 40, and the ECG sinus tachycardia with RVH and S1 Q3T3 pattern. Oxygen saturation is reduced 85%, positive troponin and normal creatinine. The echo showed severe tricuspid gauge, pulse elevated, dilated right side, TAPSE is reduced, positive McCollin and 6-6 sign, and a saddle-shaped bilateral pulmonary embolism in CTPA. So we have again a high-risk pulmonary embolism patient with contraindication for thrombolytic, and we decided to use a mechanical thrombectomy by the penumbra aspiration because of the saddle-shaped pulmonary embolism. And we usually in the penumbra we ask the radiologist in our pulmonary embolism response team to put for us a map called pulmonary artery mapping of what he see in the CT. So he illustrates by his hand this map. So this is the place where we go and aspirate. And to do penumbra aspiration, you have to know that you aspirate the blood of the patient who is shocked. So you have to prepare at least 1 liter of fresh blood available before you start. And it is an 8 French, the available system in Egypt is an 8 French penumbra. Avoid air in your system, it has to be air clear. Once you aspirate the thrombus, you will feel that you are aspirating a thrombus. Once you have a fresh blood, you have to stop. So you are not concentrating only on the hemodynamics of the patient, you are also concentrating on what you are getting out. You are getting out this thrombus, and this is a device. It's like an aspiration device. Come with the penumbra sheath, and you have to concentrate not only on the hemodynamic, also on the blood coming up. As long as it is interrupted, it is a thrombus. Once it is a fresh blood, you have to stop aspirating, because now you are aspirating the blood of the patient. The new 16th range of the penumbra, it has a sensor. So once you put the sheath, it senses there is a thrombus or not, and start aspirating automatically. Once you finish aspiration, it stops automatically. So we hope we have this new technology. This is a penumbra sheath. It's an 8 inch. It maximally put here in the lobar arteries. You can see a huge right thrombus in the right pulmonary artery, and we put in the sheath directly this separator where it fragments the thrombus during aspiration. So you start aspiration and then you put this separator that can fragment the thrombus, and once it is fragmented, you can suck it. Then you go to the left side after changing using a hard wire, ambulance hard wire to change, and you can appreciate the high thrombus burden in the left side. And then we go with the separator as much as we can. All the segment, we have 10 segmental arteries in the right and 10 subsegmental arteries in the left. So we have to know the anatomy, which is a 3-dimensional structure. It's not easy. We have to study the anatomy before we start aspiration. This is the value of the per team with the radiology, so we can know where exactly is the thrombus. And there was a thrombus upstairs also, so we go with a separator. This is your balloon. It's a fragment, and the suction is stable in this part in the lobar branch. And if I want to show you this image, because if you can appreciate the thrombus as a black point coming downstairs. And this is thrombus before aspiration, after aspiration. This is the best system we have nowadays, and we have immediate results actually on the table. The patient blood pressure becomes stable on the table. Within 48 hours, patient blood pressure is 140 or 90, heart rate is 70, respiratory rate is normal, oxygen saturation improved. We usually go, also we keep a big tail in insured patient and give intracoronary heparin, intrapulmonary artery heparin, unfractionated heparin for 48 hours as long as the patient is shocked. And after that, we give enoxaparin every 12 hours for 7 days. Then we start the oral NOAC system. And after 1 month, we did a CTPA with no pulmonary embolism. Patient is good and well for 8 months now. This is my last case. He's a young pharmacist, 20 years old. He has a DVT history from 1 year and was diagnosed as antiphospholipid syndrome. He was not on regular treatment. He's just 20 years old kid. He presented to the ER with acute dyspnea, right lower limb pain, and frank hemoptysis, tachycardic, shocked, tachypneic, sinus tachycardia following the ECG, oxygen saturation reduced, hypoxic, positive troponin and normal creatinine, and by echo, dilated right side, positive 60-60 and reduced stapsin, and the pulmonary angiography showed bilateral, more on the left side pulmonary artery segmental and subsegmental also extension. So we have a high risk pulmonary embolism, but no contraindication for thrombolysis. And because he's young, we want to give him the best benefit, and we can do it. So we sought to use the ecosystem. What is the ecosystem? It's ultrasonic waves with two catheters, an ultrasonic catheter which give ultrasound, and an infusion catheter which infuse the thrombolysis and saline to keep the system not very hot, because when you give a lot of ultrasounds, it makes a lot of heating, so you have to calm down the system by saline plus the infusion of altiplase, and you connect both of these catheters into the hub or console on the right side. And the idea is that the ultrasonic waves unwind or separate the fibrin threads inside the pulmonary embolism to allow the altiplase small dose, very small dose, 1 milligram per hour. So in total, in 6 or 8 hours, continuous infusion of this altiplase pushed into the thrombus by the ultrasonic waves, accelerating dissolution of the thrombus without fragmentation. This is the value of this ultrasound. It does not fragment the thrombus, it distributes the thrombus in place, not like the big tail we fragment it, so we have this like no reflow phenomenon. No, here is dissolution without fragmentation of the thrombus by the ultrasonic wave. So we identify the anatomy, then we, by a simple wiring technique, we put the sheath, connecting sheath, then we put this dotted ultrasonic waves, and we finished. You don't do anything, very simple procedure, the ecosystem. However, the cons and the problem what we have is it needs a long time, 6 to 8 hours, to have good results. Not on table, you have the results. The caster has tiny pores to allow the saline and altiplase to be pushed outside. And we are used as a cardiologist, once we reach the distal space, we do aspirate to take the blood is coming out. Once you do that, you close the tiny space and you destroy the caster. So don't do aspiration. Again, once you reach with the ultrasonic waves inside, you finish the procedure now. And now we are in the case lab. In Acute University, the case lab is not at the same level of the CCU. So the case lab is in the first floor, and the CCU is in the second floor. It takes 20 minutes to put the patient from the case lab to the CCU. So we told, okay, we will connect the device upstairs and start ultrasonic waves. This is wrong thing, and it resulted in a block in the system, and we need to actually change the caster, which is extremely expensive nowadays, around 200,000 Egyptian pound now, because you have to start ultrasonic wave immediately on table and move with like a generator upstairs. Don't wait, because during waiting, this caster will be blocked. However, after 1 hour, the patient upstairs, we started to connect, start to give us something is going wrong. It's blocked, so we have to come back to the case lab, change the whole system, do the procedure again in this shocked patient. However, he was lucky, and we learned from him a lot. Within 48 hours, patient is stable, blood pressure. Actually, one of the best results in the mean pulmonary artery reduced to 15, maybe because it's not only fragmentation, but also giving thrombolytic inside, so it have a very good results. We continue on enoxaparin for 7 days, and warfarin, no, because he's antiphospholipid syndrome. And after 1 month, we do the CTPA with no pulmonary embolism, and he has 3 months now. His patient is very good and well. So my take-home message is catheter-directed therapy in high risk and intermediate high risk, as shown by Professor Ahni. Patients who has contraindication for thrombolytics or had failed systemic thrombolytic are indicated for CDT, and in pulmonary embolism response team is very useful, and we have to initiate it as early as possible for decision making and choosing the good therapeutic choice. Thank you very much.
I have a question, Ayman. Regarding the ecosystem, how far does the shock wave, or not the shock waves, the ultrasound waves are transmitted? Do they go beyond the vessel where the ultrasound catheter is settled? or just work on this segmental or whatever pulmonary artery, because in this case you have to readjust it frequently.
Yes.
And the second thing, do you think that the penumbra alone also is sufficient, or we could just improvise by doing like a manual thrombectomy along with also thrombolysis catheter-based? I mean, also, is it possible to do a hybrid technique or some sort of merging both techniques together, or is it not?
Okay, I will take the advantage that Professor Ahlan is with us. So I will answer the first question about aqueous length and efficacy. And I want your advice on what I'm saying. So there are two lenses in the aqueous system, 18 and 12. So the length of the ultrasonic wave length is important, because the longer the length, the more effective is the ultrasonic wave. So you have to use it depends on the length of the thrombus you mapped with the radiologist before. This is first one. Problem is that thrombus is not in one artery. It's in a lot of arteries. So it actually you choose the biggest one and put inside it the ecosystem, biggest and most secluded one, and wait for the effect of this ultrasonic waves to be transmitted. Hopefully, by studies they say that this is transmitted and has a good result. Actually, we have seen a good result. What do you think, Professor Ahlan?
I mean, first of all, congratulations, excellent case presentations and very useful. I don't have really much to add, but I would like to raise the attention again to what you mentioned with the penumbra case. You made the very important point that once you use thrombectomy, you have to be aware of the blood that you withdraw the patient. I'm not so familiar with the use of the new Indigo device. So thank you so much. And first of all, I would really like to thank the organizers for inviting me. And it's a pity that I couldn't attend in person. And I hope I will be able to do this in the coming years. And I would like to give you a short overview on catheter-based therapy for pulmonary embolism. I guess a lot of you already use it in different hospitals. These are potential conflict of interest. As far as I can judge myself, there are no conflicts of interest regarding this presentation. Let me bring you back to the ESC guidelines for pulmonary embolism. They are already a bit of age. However, it will take a few more years until we get new guidelines. So these guidelines are still valid. Looking at the risk stratification, you all know that there is a high-risk pulmonary embolism who requires immediate action, and if the patient is eligible for thrombolysis, so this is still the mainstay of high-risk acute pulmonary embolism. However, you also see a lot of patients that come to the hospital who are something like an intermediate risk, and some of them may deteriorate into high risk. So therefore, the European Society of Cardiology tries to distinguish the intermediate risk pulmonary embolism, which most of the time are diagnosed by CT angiography, and you do see a massive embolism more or less in both sides of the main pulmonary arteries, but the patient is still not hemodynamically in shock. So these patients can be distinguished into intermediate high and intermediate low. And currently there is a big effort of research going into the area. Do we have any additional clinical or biomarkers or clinical assessment tools that allow us to determine which patients are actually in the intermediate high-risk category that are likely to deteriorate into a high-risk pulmonary embolism? And these are the patients that are potentially eligible for systemic thrombolysis. There is an ongoing trial. It's the PATO-3 study, you may have heard of it, and that currently assesses patients with intermediate high risk who are either treated conservatively or who are treated with half-dose thrombolysis. So we are waiting for the result of this trial, which will probably be finished in the next year. And on the other hand, we know from some of the registries that are available for some of the catheter-based interventional treatment therapies. That, for example, here this is the FLASH registry. That's mainly patients from North America, and a lot of the procedures that are done in the FLASH registry are done by radiologists. So it's a thrombectomy device. I will briefly elaborate on that a bit later in the presentation. Looking at the patients that have been included in this registry, you can identify patients that are in an intermediate high risk category, and the authors tried to determine this, and they called it normotensive shock. So it is patients that don't have criteria that are yet fulfilling the shock criteria, but patients who are very likely to develop shock and who may already be in the phase of going into hemodynamic instability. And the factors here are illustrated in that slide. So it's a combination of biomarkers, of RV function, and then of course of the image morphology of the pulmonary embolism. So if it's a saddle PE, meaning a riding thrombus on both sides of the pulmonary arteries, which can be seen in a CT scan, if the patient also has a concomitant deep vein thrombosis, and if the patient is tachycardic, but the patient is not having a severe hemodynamic compromise assessed by systemic blood pressure. So applying these criteria into this intermediate high-risk category patients that have been treated with thrombectomy in the FLASH registry, you do see that 1/3 of patients are qualifying as patients with normotensive shock. So this just indicates that within the category intermediate high risk, there is a large proportion of patients that are very likely to deteriorate, and these are potentially the patients where the upcoming catheter-based treatment strategies could potentially provide a benefit compared to the standard therapy, which is not thrombolysis at this stage. Looking at the elderly patients, which is something we face in most of the Western countries. I'm not so sure about Egypt, but I guess you will have a lot of elderly patients in the future and decades as well. We do know that from the PATO studies, the initial ones, thrombolysis is associated with a higher bleeding risk. So especially patients aged 75 and older are more likely to have major bleeding if they undergo treatment with thrombolysis. So this underscores that there is a growing need for alternative reperfusion therapies for pulmonary embolism, and we do need a structured assessment of patients with acute pulmonary embolism according to risk stratification regimens. We also do need a rigorous scientific assessment of all these new reperfusion techniques to determine the value and place in acute pulmonary embolism. Of course, a lot of these therapies are already used on a routine basis in several hospitals. And also, this is my personal belief, that we have a need for rapid interdisciplinary decision-making in patients with acute pulmonary embolism, because it's most of the time not the cardiologist in the cath lab who does see the patients at the first time. So it is most of the time the emergency department, or it is within the hospital, it's post-surgical patients. So we need an interdisciplinary team that of course consists of cardiologists, but also consists of other disciplines, and they need to be aware of what has to be done in terms to assess patients who are at intermediate high risk and who may deteriorate. And then we need to have these therapies available on a 24/7 basis. It is probably not necessary to wake up at 2 a.m. in the morning to treat someone with intermediate high risk pulmonary embolism who is not in shock. But on the other hand, it doesn't make any sense that this patient comes in on a Friday night and the cath lab opens on a Monday morning, and then more or less the whole benefit that could be derived from these therapies in pulmonary embolism may have been gone. So what are the alternative reperfusion therapies? That's the title of the talk that I have been suggested to give today. We do have two different principles. We have the catheter-directed thrombolysis, CDT, and that is mainly one of the devices which is also supported by ultrasound pulses. It is ultrasound accelerated thrombolysis, and this is a system that is placed to the pulmonary artery. If it's a lateral pulmonary embolism, you need 2 catheters placed in both of the arteries, and you apply a very low dose of thrombolytic, and that is supported by ultrasound. And the idea is that the catheter goes throughout the thrombus. The lysis is more or less being sequestered into the thrombus, and there is the mechanical impulse of the ultrasound that helps disrupting the fibrin. Then there is the catheter-based thrombectomy, and this is a therapy that has recently been rapidly evolving just through the availability of more flexible large bore vascular access. And some of the catheters use manual aspiration, and some of the catheters use a vacuum pump, which is, for example, the Penumbra system. So these arrows just mark the probably more widely used devices, but there's a plethora of companies currently developing these devices, and we don't know yet whether these are devices that will dominate the therapy in the future. And we also have not seen any randomized clinical trial, but these are ongoing. Looking at the more widely used devices, the catheter-directed thrombolysis more or less comprises the so-called ecosystem, and these are the two plugs here that you can use for the perfusion pump that allows the delivery of a thrombolytic directly into the pulmonary artery. And then there is also this other channel here that applies the ultrasound pulses directly to the place where the catheter is crossing the thrombus. Normally it would run for about 6 hours. There are shorter protocols available. And this for sure is nothing for a patient who is hemodynamically unstable, because the therapy will need a few hours. On the other side, there is the catheter-based thrombectomy. And one of the most widely used devices is the flow retriever. I referred to the flash registry earlier on in this presentation. So the flash registry has been done with the flow retriever. And of course, there's also the Indigo system, which uses that vacuum suction pump, and it's a bit smaller in size. Both systems work very well in terms of rapidly extracting the clots from the pulmonary circulation, and the patients do recover during the procedure. So it's a bit like a STEMI procedure. You do see directly what you do with the patient, and you can see the removal of the clots. Of note, the patients don't need thrombolytic, but they do need anticoagulation during the procedure. So it is not that you can do it without any heparin. Of course, you need some anticoagulation, but this is probably less critical as the application of a low-dose thrombolytic. For example, if a patient undergoes a major surgery, abdominal surgery, for example, for pancreatic cancer, and develops a fulminant thrombus in the pulmonary artery, and there is a contraindication for lysis, so then the catheter-based thrombectomy is something that you can apply immediately, and you just need to apply unfractionated heparin. What is the evidence? The evidence is only from registries, and the endpoints so far were the RV-LV ratio and some of the more measurable endpoints in terms of the consequences of pulmonary embolism, but not hard clinical endpoints such as recurrent pulmonary embolism or death. So there is currently major studies going on that are randomized, and one of the studies is the HI-PITO trial. This is in intermediate high-risk patients with pulmonary embolism, and they will either be randomized to standard of care, which is of course not thrombolysis, it's anticoagulation, and the catheter-based thrombolytic therapy using this ecosystem. And this is the protocol, and the primary endpoint is 7 days post-randomization, and it's a combination of mortality, recurrent pulmonary embolism, or hemodynamic and respiratory decompensation or collapse. So this is a hard clinical endpoint, and the number that they are currently recruiting is 406 patients. We are half through the study, and we're really waiting for the results, and hopefully that might be available within the next year. The other study that is currently progressing fast is looking at the catheter-based thrombectomy with the flow retriever system, the large bore access to remove the clots from the pulmonary circulation. And here it is compared not to standard therapy, it is compared to catheter-directed thrombolysis, any device. Of note, the company started another trial which is currently in the initiation phase, where the catheter-based thrombectomy with the flow treatment device is, of course, compared against the standard therapy. So there's two different trials going on. The first one will be the peerless study that will show us whether this is superior to the catheter-based thrombolysis. And the primary endpoint here is a bit different from the high-PITO study because it also contains a bleeding endpoint. So it's not only mortality, hemodynamic respiratory deterioration or bailout therapy, it also contains the bleeding endpoint. And this is a randomized trial, and we're also waiting for results and probably within the next year or the year after. And it is not the only two trials that are randomized in this field. As you can see here, this is the evolving clinical trial and registry setting of catheter-based therapies in pulmonary embolism, and we are currently somewhere over here. You see the high-PITO study, you see the peerless study, but there is also the study that uses a different device, the PE-TRACK study, Betula study, Stratify, and some others. So it is a very fast developing field without any results of randomized trials yet. So it is very important to see what the results of these trials are. On the other hand, we do have techniques now available that we can apply to patients that are not eligible for thrombolysis. So this is probably one of the main points why these techniques have been used in the past already. And in the US, for example, a lot of patients are treated with thrombectomy for several reasons. And we did an analysis of a US database that dates back to 2016 in patients with pulmonary embolism. And we divided them into different age groups and also regarding frailty. And if you look at the baseline characteristics, they are very close, except that dementia, of course, is more often seen in frail patients, and cerebrovascular disease is more often seen, and obesity is less seen in frail patients, which is according to what we would expect from the clinic, so that you see more patients who have poor nutrition status and who are frail. So looking at this registry and looking at the different available therapies, be it systemic thrombolysis, surgical embolectomy, or the catheter-directed treatments, you do see that the catheter-directed thrombolysis has been around for a while, and there has been an increase in some years, and it is being used more often as the catheter-based thrombectomy. However, you note that, let's say, probably around 2018, at least in North America, there was a steep incline in catheter-based thrombectomy, so that this therapy is relatively often used in pulmonary embolism, although we don't have data on clinical outcome yet. But of course, there are patients that otherwise would not be treatable, and catheter-based thrombectomy appears to be a relatively safe approach if it is done in a setting where people are used with stiff and long wires. And most of you who do structural heart disease procedures know how to use the wires, and most of you will have done any right heart catheterization. So in the hands of cardiologists, I personally think it's a very safe tool to use. Looking at the outcome in this registry, it is quite evident that either compared with catheter-directed thrombolysis or systemic thrombolysis or catheter-based thrombectomy versus surgical embolectomy, that you do see less bleeding complication, but that is something that you would expect from these procedures if it is just about the bleeding complications. However, we don't know whether mortality, recurrent pulmonary embolism, or deterioration will be affected by this treatment compared to the standard therapies. And we are looking forward to the results of the clinical trials that I've briefly pointed out. So in conclusions, patients with acute pulmonary embolism at intermediate high risk or high risk should be brought to the attention of a local PERT. As far as I understand, there has already been a talk about PERT, or there might be a talk later on. So this is quite important that you have a team, and the team needs to be composed according to local standards. And I think that interventional cardiologists must be part of this team, and I think that this sort of treatment should be available 24/7. Therefore, a cath lab setting might be ideal to establish catheter-based treatment of pulmonary embolism. And if judged as high risk or intermediate high risk by PERT, and if primary thrombolysis is not the preference of these patients, then of course the patient should be transported to the cath lab immediately, and an interventional treatment, be it local regional thrombolysis with a catheter-directed thrombolysis or catheter-directed thrombectomy should be applied. Minimum requirements for PERT: you should have SOPs for diagnosis and risk stratification in the emergency room and the ICU for these patients. The team members, as I mentioned, there should be a cardiologist, and 24/7 cath lab should be available. Of course, you need the radiologist for a CAT scan, and the surgeons might be necessary to assess the perioperative patients for acute PE. And you can center more specialties around this. You can make it very big, but this is the minimum requirement. And you need 24/7 trained staff in the emergency room and ICU. And I thank you for your attention, and I'm available for any questions.
Thank you very much, Professor Aaron. It was very nice lecture. Can I ask you a question? Which patient you choose for the ecosystem, the ultrasonic directed thrombolysis, and which patient you use for the inari or the penumbral aspiration? So both are contraindicated for thrombolytic, and you are using CDT for these patients. Which of to choose?
So if there's a high-risk patient that I can't treat with thrombolysis, I would go for the thrombectomy.
Yeah.
Because even the very low dose of thrombolytic that you apply with the ecosystem, for example, the catheter-directed thrombolysis, may be of harm for this particular patient. But I have to disclose that we also use these two systems in patients with intermediate high-risk pulmonary embolism, where we clinically judge that the patients may have a benefit from this therapy compared to the standard therapy of oral anticoagulation. There's no data yet supporting that we should do it, so it's an individual decision, and we base the decision on many points. We base it on echocardiography, we base it on the CAT scan if it's a bilateral massive pulmonary embolism. We also base it on the heart rate. So according to what I've shown from the FLASH registry, so if you have tachycardia, so if there's a patient that has 115 heartbeats per minute, but systolic pressure is 100, so there is no shock. But if that patient has signs of right heart impact from the pulmonary embolism in the echocardiography, and if there is a one-sided or both-sided massive pulmonary embolism, then we would, of course, think that this might be a patient where we can apply the therapies that we have available. And as large bore access may be associated with more complications later on regarding bleeding, then we would normally tend to choose the catheter-directed thrombolytics of these patients because the access is smaller. But this is just our own approach. Sometimes we decide for thrombectomy, sometimes for catheter-derived lysis, but most of the time we treat the patients also conservatively according to the guidelines. And of course, we use these therapies for bailout situations in patients that are post-surgical.
Yeah, I have another question actually. Any question? Yeah, تفضل دكتور عباس تفضل. We have a full room here, and all are interested in the pulmonary embolism.
Thanks, for this elegant talk. I'd like to ask one question. Is the presence of massive DVT in the iliofemoral vein could affect the route of entry for thrombectomy, or you can deal with DVT first before pulmonary embolism? What is your steps you perform in such scenario?
Yeah, it's a very good point. We tend to use sonography in the cath lab if we have it available. we actually are in the process of buying a new echo machine, and the old one is now based in the cath lab. So we have it available. And if we do, for example, structural interventions like a tricuspid or mitral valve, and if we use large bore access for the veins in the femoral veins, we tend to use sonography to puncture. So we would actually then anticipate to see a thrombus or not to see a thrombus, and then either decide to go on the contralateral side. So having a deep vein thrombosis extending into the iliac veins in both sides would be very seldom. So we have never really approached this patient so far. So therefore we are taking responsibility by using the sonography. But it is not mandatory, and it is quite seldom that you have a thrombus there. And even if you would have a thrombus there, and even if you would mobilize the thrombus, of course, it's not something you would like to do, but then you are able to capture the thrombus with the catheter when you enter the right atrium of the ventricle. So I would advise, if available, use sonography. But in the clinical setting, it has not occurred as a major issue so far, at least in our setting, that we came across patients where we are afraid of puncturing the vein and seeing a big thrombus on the side.
So what I understand is it doesn't matter. Mostly it's unilateral, so you use a contralateral. And if it's bilateral by chance, it doesn't matter because you are going to go to puncture and you will catch the thrombus upstairs.
Yes, but we never had the bilateral.
Yeah, it's fair, yeah. And last question.
Any question?
If you have the, do you think that the aspiration is more powerful and has a more future than the aqueous ultrasound or not?
Difficult, because you may also see rebounds. If you're familiar with hemostasiology, and if you have a thrombus in the vessel, you know that there is a burst of thrombin production that also originates from the platelets. So whatever thrombus remains there is a source of new thrombi that may develop. So therefore, it's important to have these patients anticoagulated, and the best choice would be unfractionated heparin, because you can antagonize if the patient tends to bleed. So the problem is not over once you have the thrombus out of the system. There may be a recurrent thrombus. And whether the catheter-directed thrombolysis might be better in this setting, not known. Maybe we get some answers from the PLS study, but then looking at the endpoints of the PLS study, the endpoints are not really looking so much at recurrent thromboembolism. They're looking at endpoints such like death, deterioration, but also at bleeding. Yeah. So not sure if we can answer this, but in theory, I don't see that one of the two systems would have a theoretical advantage.
Any more questions? Okay, thank you very much for your time and your appreciation. And if you want to, we would like to have your impact on the cases we are going to give. It will be very nice.